The question about switching from Jade to Jade comes up frequently. Some patients raise it themselves. Sometimes we raise it when they come to their office appointment. And in general, we have switched all patients from Jade to Jade as we identify the patients, they come for their appointment or they're due for their next prescription. My approach has been to go over the benefits of Jade, particularly with respect to tolerability that seem to occur, and patients are enthusiastic in general to want to switch. We've hit a few bumps in the road with some insurance, but in general, this has been a relatively easy thing to do and certainly favorable to the patients. For patients who have not been on an iron chelator therapy, I think the dosing is pretty straightforward, and I do follow the guidelines for Jade. This would be a dosing of 14 milligrams per kilogram per day, and I stick to that pretty closely. For a drug that's newly available, I have not generally wavered too far from the dosing recommendations, and those seem reasonable to me. So a new patient starting iron chelation therapy, the 14 milligrams per kilogram seems like a good place to start, and then the dose can be increased as the patient needs in response to either degree of iron chelation and tolerability. With respect to patients who have already been on Jade, that question is sometimes a little bit more difficult to answer. I've generally used the rule of taking the dose of Jade that they've been on and multiplying it by 0.7 or 70% of the dosing to get the new dose of Jade, which has been the recommended way to do this. I generally would not start at a higher dose of Jade than an equivalent dose of Jade. Occasionally we've started a little bit lower, partly from just rounding of doses, or partly just out of an overabundance of caution, just to make sure the patient's tolerating the new formulation well. The last thing that I want is a patient to start on Jade and have an adverse event and then be demoralized from chelation therapy in total. So we've lean towards maybe a little bit lower dose to start. Once I know the patient tolerates it, we have ramped up reasonably quickly. The role of adherence or compliance in patients with iron chelation therapy has been a problem with Jade. I think everybody would appreciate that. It seems to be a bigger problem in patients with sickle cell disease, perhaps because of the lactose in the Jade product. But there are patients with other diseases who have certainly had difficulties with adherence to the drug regimen as well. The role of Jade seems to be able to obviate a lot of these problems and move forward successfully with further iron chelation therapy. There are several ways to assess adherence to therapy, even without counting pills. One is to just ask the patient how they're doing with their medication. That is a simple way. Brings trust and bonding with the patient, so they know we're interested in their care and we really want an honest answer whether or not they can tolerate their therapy or not. Another way is to see if the patients have refilled their medications, and there certainly is a drop-off in the patients refilling their medications, particularly with Jade, and that gives you some sense of their compliance if they're not going back for their refills at a scheduled time. And then the third way would be to just assess the iron load, mostly with the ferritin. That's probably the least successful way because the ferritin does tend to bounce around a little bit, and so it's not a perfectly accurate or sensitive way to monitor adherence, at least in the short term. The treatment of patients with sickle cell disease is evolving over time for the better. Without any home runs in therapies such as gene therapy or stem cell transplant, patients are doing better. They are living longer and their quality of life is improving. That was brought forward to me in a recent support group meeting that I had with patients, where I asked them if they think their care was better now than it was 20 years ago. these are adult patients who are in their 40s and 50s with sickle cell disease. And universally, the answer to that question was yes, that they felt like their care was better, more streamlined, and more effective, even in the absence of major changes in therapy that have been able to cure the disease. So I think part of that also involves effective use of transfusion therapy and treatment with hydroxyurea. And one of my goals has been to try to get most patients with the severe forms of sickle cell disease, hemoglobin SS or hemoglobin S beta 0 thalassemia, on some sort of disease-modifying program, which would include transfusion therapy or hydroxyurea. And I think that has been reasonably successful for many patients. And part of effective use of transfusion therapy, by definition, I would say, would be chelation management. And so the ability to do chelation therapy more effectively now becomes really part of the standard of care, I would say, for transfusions and for patients with sickle cell disease.